Good morning, dear colleagues. Bom dia a todos. Welcome to the third edition of Club APIC, an initiative of the Portuguese Association of Intervention Cardiology. At Club APIC, we intend to promote sharing of knowledge and discussion of current topics in the area of interventional cardiology. As president of APIC, I'm pleased and glad to announce the presence of a special guest in this third edition of Club APIC, Dr. Simone Biscaglia, to whom I thank you in advance for your presence and friendship. Thank you, Simone, for your presence here. Simone Biscaglia is an interventional cardiologist at Ferrara University Hospital in Italy. He is the author of more than 100 articles, very interested in coronary physiology, and he is the FIRE trial PI, the main investigator, which will be the topic of this edition. FIRE trial was presented in the last ESC Congress and published in the New England Journal of Medicine, and it is a dedicated trial that aims to evaluate the efficacy and safety of complete revascularization after MI, specifically in older patients. Older patients, we all know that they are poorly represented in conventional randomized controlled trials. And on the other hand, older patients with acute MI are a rapidly growing population in our cath labs and presents a unique treatment challenges for us due to its frailty and also the presence of more complex coronary artery disease. That's why this data is so interesting. I invite all the participants to the discussion freely using the chats throughout the session. This Club APIC is going to be present with the collaboration of Hospital de Braga. Carlos Braga, you can announce your colleague to present the FIRE trial.
Thank you, Rita. First of all, I want to thank you, Rita. First of all, I want to welcome Simone. It's a good friend of us, of APIC. Thank you for being with us at Club APIC. I will invite you to participate after the presentation of Fernando Mané, cardiology resident from Hospital de Braga, and then we will discuss the results of the FIRE trial. So, to you, Mané. I will share the presentation. Can you all see the presentation?
Yes.
Okay.
Hi, good morning. My name is Fernando. Thank you, Carlos, for the presentation. It's a pleasure to be here presenting the FIRE trial that, as it was said, was published in the New England Journal of Medicine and is entitled Complete or Culprit-Only PCI in Older Patients with Myocardial Infarction. First author, Dr. Simone Biscaglia. I have no conflicts of interest to declare. As we all know, coronary artery disease is a relevant condition in older patients, as 20% of these patients develop myocardial infarction. A significant percentage of these patients, about 55%, present with multivessel disease and are at higher risk for complications, both hemorrhagic and thrombotic. We know that complete revascularization is well established in STEMI patients, younger STEMI patients. However, older patients and then STEMI patients are underrepresented in the studies published to this date. In relation to physiology-guided revascularizations, there's still uncertainties in its advantage over angiography-guided revascularization in this group of patients with myocardial infarction. However, it is an attractive option for patients where a high burden of complications and comorbidities are present. It seems an attractive option. So with this in mind, the authors of this trial designed a randomized trial involving older patients with myocardial infarction and multivessel disease to investigate whether complete revascularization that is performed on the basis of coronary physiology is superior to Culprit-Only PCI. So with this study, several gaps in evidence are addressed, such as the older patients that are not included in previous trial or are underrepresented in previous trials, including patients with more than 75 years old. It also includes all the spectrum of myocardial infarction with patients with STEMI and STEMI, and also investigates the physiology-guided multivessel PCI in a group of patients that were underrepresented in previous trials. So it included patients from 34 centers in Italy, Spain, and Poland with more than 75 years old, myocardial infarction, multivessel disease, and successful PCI of the culprit lesion. Exclusion criteria included planned or previous surgical revascularization, left main as non-culprit lesion, inability to identify culprit lesion, or a life expectancy lower than 1 year. So patients included were randomized to either culprit-only PCI or physiology-guided complete revascularization that could be done during the index procedure or staged in the index hospitalization. Strategies for physiology guidance could have been wire-based or angiographic-based, and the patients were followed up for 1 year, and the results presented in the study published are the ones in respect to this follow-up. The primary outcome is a composite outcome of death, myocardial infarction, or ischemia-driven coronary revascularization. Authors also included a key secondary outcome of a composite of cardiovascular death and myocardial infarction, and the safety outcome of contrast-associated acute kidney injury, stroke, or bleeding according to the BARC definition. The study included 1,445 patients, 76% of the eligible ones, and the crossover between groups was rather low, below 3%. Regarding the baseline characteristics, it's important to highlight the median age of 80 years old, of about 80 years old in both groups. It's also important to highlight the high burden of comorbidities such as diabetes and chronic kidney disease, and also important that the most common clinical presentation in this group in the sample of patients was STEMI, about 65% in both groups. Regarding procedural characteristics, radial access was done in a high percentage of patients, about 94%. And it's also important to highlight that angiography-based physiological assessment was done in about 35% of the patients. Functionally significant non-culprit vessels were present in 45% of the vessels that were assessed. Regarding the primary outcome, we can see that the primary outcome was reached in a higher percentage than previous studies that analyzed younger populations. However, the complete revascularization arm, in the complete revascularization arm, the primary outcome was reached less frequently, and with a hazard ratio of 0.73 and confidence intervals ranging from 0.57 to 0.93, with a number needed to treat of 19. The key secondary outcome was also less common in the complete revascularization arm, with a hazard ratio of 0.64 and a number needed to treat of 22. There were no difference between between groups in the safety outcome, despite the higher percentage of complications in the complete revascularization arm. There are several limitations that could be highlighted from this study. It's open label design and the limitations inherent to this design, and also the results could not be applied to patients where complete revascularization is done outside index hospitalization, or where complete revascularization is guided only by angiography. Also, the decision on invasive treatment before randomization could have affected the group of patients included in this study, because some patients may have been excluded based on clinical decision before decision on invasive treatment. Also, age may not reflect the frailty of patients or the number of comorbidities present in this group, in the group of patients analyzed. However, the FIRE trial is a highly relevant trial as it included patients with more than 20 years or 20 years older than the ones included in other trials. It also included patients with a higher prevalence of NSTEMI, the most common acute coronary syndrome presentation among older individuals. Also, physiology-guided strategy reduced the number of interventions needed in a population where there is a high burden of complications. So the authors conclude that among patients aged 75 years or older, myocardial infarction, multivessel disease, physiology-guided complete revascularization was associated with a lower occurrence of the composite of death, myocardial infarction, stroke, or ischemia-driven revascularization. Thank you for your attention, and I'm looking forward for the discussion.
Okay, thank you, Fernando. Excellent presentation. I want first of all to congratulate Simone for the excellent trial that he did. Nowadays, we know more about older patients and how to treat them. All of you can send questions through the chat, and we will try to comment those questions. I'll invite also Sergio Madeira to discuss with us the trial. I have a first question for Simone. The question is about the use of QFR, which is a novel physiology-guided tool based on angiography. 35% of patients were treated using QFR. Did you find any difference between QFR and FFR? And what do you think about this new technology? It will aid us in the future to decide which patients to treat and which lesions to treat.
Yeah, thank you, Carlos. So first of all, congratulations to Fernando. Your presentation was actually better than mine, so congrats. And yes, I am very happy to be here with you because you know that I love APIC, I love you guys. So it's always a pleasure to be with you, even if only online. So as for, yes, we utilized QFR in the study. So maybe all of you know that QFR is an angiography-derived fractional flow reserve. So it's a three-dimensional reconstruction of the vessel with the estimation of the flow. So we can estimate FFR without using the wire. And as you know, in the FIRE trial, and as Fernando said, we included both ST segment elevation MI patient and non-ST segment elevation MI patient. And the choice regarding physiology was left at the operator discretion according to their organization and the tools they had in the cath lab. And basically what the investigators decided to do was to perform QFR mostly in STEMI patient. And this actually for me makes a lot of sense because in STEMI patient, you perform your primary PCI, it's 3 a.m. in the morning, and probably you do want to open a pressure wire to put adenosine or another drug to perform the evaluation of a non-culprit lesion. So what happens, at least in our cath labs, is that if you have an intermediate lesion and you want to test it with the physiology, you do it in another procedure with wire-based physiology. With the QFR, you can avoid to do it because you can perform the analysis on the projection of the primary PCI. So you have just to remind yourself to perform at least 2 projections, at least 30 degrees apart, and to perform the analysis. If the analysis is negative, the patient has not to come back to the cath lab to perform just a negative physiology assessment, but if it's positive, you bring back the patient to the cath lab to perform PCI, and you know it since the very beginning. So actually, this was actually one of, I would say, the advantages of the FIRE trial, because if you have a look at the number of procedures among the two groups, it's not double. So in the complete arm, you don't have double the number of procedure, but you have 950 something procedure in the complete arm and 725 in the culprit only. And this is due to the use of QFR in STEMI patient, and obviously to the fact that in non-STEMI patient, at least in most of the center that participated in the FIRE trial, you tend to close the patient in one procedure. So even if they are multi-vessel disease, you perform your evaluation, physiology evaluation on culprit and eventual treatment in the same procedure. So I would say that it's not one size fits all. So it's not that you have to use one single physiology tool in all the patients, but if I have to give you the answer from the FIRE trial and from our experience, is that angiography-derived FFR can be for sure useful in STEMI setting, in multi-vessel disease, whereas probably in non-STEMI patient, it would be probably more useful to perform wire-based physiology, since you are already having one procedure and performing all the assessment you want to do in one procedure. And then obviously with the invasive physiology, you can also measure the microcirculatory function, so you may have more information.
Thank you for the excellent answer, Simone. We have here so many questions. One from Miguel Santos. He asks, what was the mechanism that gave the benefit for complete revascularization? And I can add, do we expect the same in chronic coronary syndromes in older patients?
Yeah, so as you saw, basically the number of events was much higher if compared to the other trials, and this is due to the population that was enrolled in the trial, because you saw that 45% of patients at least moderate kidney reduction of function. They have 32% of patients with diabetes, 36% of patients with were female, whereas in the other trials was around 20%, and obviously we have also 28% of patients with at least KILIP class at admission. In the other trials, it's around 8%. So it was a much more complex population. If you have a look at the other ratio of the trial, they are in line with the other studies. It's not that we had a 60-70% reduction and the other trials had a 30%. They were in the same range, but having more events, and the events these patients are having are not ischemia-driven revascularization. Most of the times, the new MI or death, unfortunately. And so basically, you were able to reduce hard endpoints. But actually, if you have a look at the meta-analysis that Fernando showed, there was a tendency in cardiovascular death reduction in that meta-analysis. But this is due to the fact that the patients enrolled in the prior trial were lower risk patients. So you need more patients to show a significant reduction in harder endpoints. In our patient population was so complex that probably you had a reduction in harder endpoints compared to the other trials. Another thing we are analyzing is that probably even the fact that you are able to have a complete revascularization within index hospitalization, this can, we will have a dedicated analysis for this purpose, but what I'm actually starting to see is that the reduction is also on other hospitalization beyond MI, beyond ischemia-driven revascularization. Those patients are less hospitalized for heart failure, for high-rate atrial fibrillation. So basically, if you are able to let those patients out of the hospital, probably they will live better and longer, because you know that for those older and frail patients, each hospitalization has a prognostic impact, irrespectively from reason, even if it's for pulmonary disease. Those patients are less hospitalized, probably because they are more stable, they are able to perform, a more active life, so they are kind of better in avoiding also other issues.
Thank you, Simone. We have here another question from Pedro Jerónimo Souza from Leiria. Is there an ideal time frame for functional evaluation in acute coronary syndrome patients? like in the same procedure, same hospital stay, other time frame? What do you think? In the FIRE trial, it was all in the same hospitalization.
Exactly, yes. Per protocol, you had to complete the revascularization. You can also perform, you could also have performed the physiology in a staged procedure, but you have to perform everything within the index hospitalization. What I would say is that if you are using angiography-derived FFR, we provided data that actually if you perform the analysis on the procedure of the primary PCI, since QFR is less affected from microcirculatory function, it's as well as if performed in a staged procedure. So if you are using angiography-derived FFR, you can use the projection of the primary PCI. If you are using wire-based technology, especially in non-STEMI setting, I would say, it would be important if you perform FFR to perform obviously the evaluation of the microcirculatory function, because you know that you can have some kind of impairment, even if it's not, most of the time it's not clinically meaningful in the territory of the non-culprit lesion. So at least you know if the microcirculatory system is functioning or not. And then you may have a little bit of more context to the decision you're putting in the value of FFR, because if it's 0.81 and you have a huge microcirculatory dysfunction, probably you can think about whether this value is okay or not, or just to give you a practical example. But if you have the information, you can put more thoughts into your decision.
Can I just intervene?
Other question.
Just
Go ahead, Sergio.
Oh, it's because this last thing that Simone said. So even if we have a result with a positive result with FFR or IFR in non-culprit vessels, if we don't know the state of the microcirculation, the threshold may not be the one that we should follow. So in your study, the wire-based evaluation followed the tested cutoffs of IFR and FFR. So what happened? Do you know? I have the information about the microcirculation.
Yes, that's a great question, Sergio. So we had a dedicated sub-study in which we performed the analysis of both epicardial values, so FFR, and microcirculation. And we are just analyzing the data right now. So we will have hopefully the results for the next PCR, just to answer your question. And yes, obviously it can happen that in some cases, but what in our experience, the number of cases in whom there is a huge acute microcirculatory dysfunction in the territory of the non-culprit lesion, especially in non-STEMI patients, because in STEMI patient, I already told you that most of our investigators performed QFR. So we did not have, basically, you can estimate the microcirculatory function from QFR, but it's rather complex, and I don't know if it's still as reliable as the invasive measurement. But as for the invasive FFR, in non-STEMI patient, the rate of patient with acute microcirculatory dysfunction related to the treatment of the culprit lesion is very low. What is important in non-STEMI patient, as Fernando said in his presentation, is that you have to be able to understand which one is the culprit lesion. And if it's not the case, you cannot use physiology, because this is a very important point. Because actually we excluded a certain number of patients because we were not able to understand properly which the culprit lesion was. And what you have to avoid 100% is to perform physiology in the culprit lesion of the ACS. Because if it's negative, you leave the culprit lesion untreated, and this is very bad for the patient.
Thank you.
Simone, I will add a question regarding those vulnerable plaques, because physiology will reduce the non-culprit PCI by about an half when compared to angiography-guided PCI. And what do you think of vulnerable plaques? Do you think that we should use also intracoronary imaging when we have some doubts?
Yes, we had two dedicated sub-studies, one with IVUS smears and another one with OCT. So basically what we did was to perform in around 100 of patients the analysis with IVUS smears or OCT in patient with negative FFR in order to understand which is the rate of vulnerable plaque in this patient population, because I understand that in younger patients you may have a higher percentage of vulnerable plaque, but in older patients probably the type of disease is different, it's much more calcific, diffuse, and so on. So we will have the data about it. But if you have also a look at the last trial that was published in JAMA Cardiology, if you have a look at the rate of MI of those vulnerable plaque that were found by OCT, it was 0.7%. So it's, I mean, we have to understand a little bit better what to do, but we are not talking about a huge number of patients with MI due to those vulnerable plaques, at least right now. We will have, you know, the Interclima, the vulnerable trial from our Spanish friends who are performing trials in this setting. So we will have more information in a couple of years. But as for now, I think that, yes, there may be some vulnerable plaque left behind, but the rate of events related to those vulnerable plaque is not very high at the moment. And I don't know if the treatment of those vulnerable plaque is PCI or probably a more intense medical treatment. We have a lot of new drugs, PCSK9 inhibitors. We have, you know, bempedoic acid. We can probably use a much more intense therapy in those patients and see whether this can be good, because those patients have 30% diameter stenosis, you know, most of the times 40%. So I don't know if the stent is the therapy in those patients.
Yes, I agree, Simone. Wonderful discussion. Unfortunately, we have to end this third edition of Club APIC. I think that this fire trial could really change our practice in these older patients. I would like to thank all the participants for your presence, special for you, for our special guest, Simone Biscaglia. Thank you for accepting our invitation. Obrigada a todos. Recordo que esta iniciativa se repete na primeira quinta-feira de cada mês e convidamos-vos a estar presentes na próxima edição do Club APIC. Muito obrigada. Thank you, Simone, again.
Obrigado.
And thank you to
Thank you.
Hospital de Braga. Bye-bye.
Obrigado a todos.
Bye, guys.